Okay, we just talked about care planning. Critical pathways or care paths are another way to do that care planning. The thing is, these things have gone through several permutations over the years. They've been called many things: critical pathways, clinical pathways, concept map, care map, you name it, they've been called it. But basically, it's still the process of anticipating and describing in advance the care the clients with specific cases or diagnoses require. So for instance, if your patient had a colon resection, that's a surgical procedure, we would have a care map for the day of surgery. So the day of surgery would probably say, bed rest or up to chair, depending upon what time of day they got back from the operating room. It would say, that their NPO, vital signs Q4 hours. I mean, it would give you all of these things, not only tasks, but care. So things like managing pain, turning them in bed to maintain their skin integrity, checking the wound. All of the things that you would be doing for that patient would be on that map. So then the next day, when it's post-op day 1, there would be another map for that same patient, but now it's post-op day 1. And on post-op day 1, well, now we're going to ambulate in the hall, TID. We're still going to be on Q4-hour vital signs, but now we're going to be doing other things. They're still going to be NPO. They're probably still going to have an NG tube, but you'll now be monitoring the drainage more. It's just going to depend on that specific diagnosis, and so that care map is going to give you very specific direction. The beauty is, for new nurses, you can kind of look at the care map and go, okay, I'm not really sure what to do with this patient. Maybe I've never taken care of a post-op bowel resection before, but now all of a sudden you have this map to show you how to do it. I think you can figure out, though, that this takes a lot of front-end work. You're going to have a bunch of people get together and agree on what the normal course will be for that patient, and that's what will be on that map, and you'll have to do it for every single diagnosis. Then your job as the nurse is to look at that map and compare what's on that map, meaning what you're expecting to do for that client that day, and then comparing it to your actual patient. I mean, maybe your patient isn't doing as well as that care map suggests they ought to be. Maybe your patient has some other chronic illnesses that are playing into this and are making, maybe they have COPD and asthma, and so getting up and walking in the hall has been really difficult for that patient. So maybe they're not walking 5 and 6 times. Maybe they're walking 2, and we're barely making that happen because they've got other chronic illnesses that are impacting it. So we're going to constantly compare our patient with what's on that care map. So basically, that care map is going to have, I'm going to show you a picture of an example of one here shortly, but they're going to have interventions for that client with a specific diagnosis, as I mentioned. And the fun thing is, everybody uses the pathway. So even if they've got respiratory coming to do breathing treatments, or physical therapy coming to get them up, everybody is going to chart on this same care map. So we're back to the nice part of, everyone's charting in the same spot. Everyone can see everyone's charting. That's kind of nice. It's supposed to, be something that we can use on a day-by-day basis to recommend how that patient should progress through their hospital stay. So it's going to have their level of activity that's expected, their pain control. Usually the first 2 days post-op, the patient's going to be on IV type medication with this type of diagnosis. But once the NG is pulled and they can tolerate liquids or even some soft food, we can move them to oral types of pain medication. So all of that is going to be planned out. Their advancement in their diet is going to be planned out. But even though that thing says on day 2 or 3, we pull the NG tube and we put them on a clear liquid diet, if this patient is not doing well enough to warrant pulling their NG tube, well, then we will not follow that part of the care map. So you don't blindly follow it. You still assess your patient, but it kind of just gives you an idea of what to expect. Then any educational topics necessary, and it's kind of a misnomer because it says, well, this eliminates the nursing care plan. That's because it is the nursing care plan. It's doing that same thing. It's doing assessment. It's coming up with problems that the patient has that we have to fix. It's coming up with a goal, the interventions, and then giving us an opportunity to evaluate how well that patient is meeting that goal. So everything that would be on a care plan is going to be on this critical pathway. Now this is an example of a very, very simple one. Tried to grab one that was not like overly difficult to read. But on this side of the page, you've got a lot of just the basic cares, making sure that, you know, we have safety taken care of. ID bracelet, allergy bracelet, side rails up, bed in the low position. Then on this one, this is a diagnosis of asthma. So their activity is ad lib. On this day, because of how far they are in their treatment, it actually recommends that the IV be DC. Now, you'd still need an order from the doctor, but you would be charting that. You do routine I&O, we take care of their hygiene, all of that kind of stuff, and this actually happens to be for a child. That's why it says, you know, parent. All of that would be taken care of here. Then in all of these open spaces, we have an opportunity to chart things that we need to chart. So if I'm doing vital signs on this person, and I'm doing vital signs Q8 hours, but there's something up with the vital signs, or there's a particular parameter, maybe on this patient, you know, it says call for systolic over 180, or call for diastolic over 110, then that additional information would be put in here, individualized for that patient. Now, hopefully a pediatric patient would never have a blood pressure that high. I'm just trying to give you an example of what you might see in there. You know, regular diet for age, that's going to be age dependent for that child. And then any other things that they want. So you notice up here, it says RT, meaning respiratory therapy, Q, and there is a blank because we can't cookie cutter this. Every kid is going to recover from asthma a little differently. So for this particular day, we will write in how frequently they're requiring their respiratory treatments. But this still gives you that care map of, okay, I need to make sure I get that done. I need to do their meds. I need to, you know, help them have activity as tolerated, but I want to give them frequent rest periods. This one I get, again, is very simplified. But you could imagine on ones that are more complicated, that have a lot more information on them, they can be both very informational, but they can also be very intimidating because there's a lot of material on that one page. Then if you flip it over, on the back side, I hope this looks familiar, because this is that charting by exception form. So we would have a place up here for date, time, and our initials, and then we've got our spot where they can write any notes about meds that they want to write, and then here is our neuromuscular, cardiovascular, respiratory, and you notice there's not a ton of information in there. It's peds, it's asthma, there's not a whole lot in there, but anything that would be normal would just get a check mark. Now, I'm probably going to assume that this one might not be normal. We're in for asthma, so respiratory, I'm probably going to have to write some stuff in there. Maybe they've still got some expiratory wheezes or some other issues. That's going to be written in that box, but all the rest of the boxes will likely just be a check mark. It's going to make writing our assessment a whole lot easier. And this particular charting by exception goes with that particular care map. So you can see how they kind of put it all together and it worked really well. Before Epic came along, this is what Mercy used as their documentation. So a lot of what they came up with in Epic was sort of based off of this. It's just when you're documenting in Epic, you'll notice there's a lot of places for you to choose within normal limits. That's the equivalent of putting a check mark in one of these boxes. Now, I've talked a couple of times about the Cardex. I'm going to show you a sample one here shortly, but the Cardex is that concise method of organizing and recording data. So I mentioned to you that it could be like a metal little flip chart that we kept at the nurse's desk, where there was a 4x6 card that we wrote in pencil so we could keep things updated, and when things changed, we weren't trying to scratch out pen, we would just erase it and put the most updated information in there. And I also mentioned to you that on the computer systems, like in Epic, either the patient summary or the professional exchange report, it kind of flips back and forth as to where they end up every time they do an Epic update. Sometimes things change. But between the patient summary and the professional exchange report, those two places usually contain the exact same information that you would have recorded on this Cardex. So it's a nice thing to have pulled up if you're giving report. It's a nice thing to have pulled up if you're calling the doctor and the doctor's asking you questions about the patient. You have a lot of information right there at your fingertips. So now this is obviously an example of a paper Cardex. So this was like an 8 by 11 sheet of paper. We put this in a notebook. I also mentioned to you guys that sometimes when we did these, instead of having them in this big flip chart with so many people trying to get to that one flip chart, we would take certain Cardexes and put them in a notebook, and the team leader would keep them in that area. Since it was only 5 or 6 patients, it was a lot easier to have people access that notebook because you're only trying to get to 5 or 6 people rather than everyone that's taking care of 25 patients trying to get to the same location to look at these Cardexes. But you can see on here, it's got their activity level, what kind of diet they're on, if there's any special instructions. So you would know, are they hard of hearing? If that's not your patient and you're going in to give somebody a hand with something, or someone's at lunch and you're running in to help toilet that patient, maybe walk them to the bathroom, it would be a good thing to know that they're hard of hearing. Any hygiene issues, are they a bed bath or do we put them in the shower? Do they have any drainage tubes? Okay, that's going to be on there. What the type of IV they have, any, jump out at you assessment information, and then, any other safety issues. Also, there's a spot down here for meds. Now, we don't generally put them all, but the meds that grab your attention. So obviously, if they're on insulin, that would be on there. They're on pain medication, that would be on there so that you are aware of that. Allergies are listed right there. You've got basically everything you need to know in a nutshell, all in one piece of paper or all in one screen on your computer. It was very handy. Now obviously sometimes it is not appropriate nor fun to have to try to document a lot of information by writing it out every single time. So we've created flow sheets over time. Now that charting by exception form, technically that's a flow sheet because it has an opportunity for that person to put in dates and times and then go down and use check marks or symbols or whatever to fill that out. But that's not the only kind of flow sheet. The graphic sheet, I'm going to show you that, but that's going to be part of that homework that I had you guys do. But that graphic sheet is another type of flow sheet. Instead of charting and writing out your vital signs, you literally go in and graph the temperature, and you just write the other stuff in the appropriate boxes, and you're done. On a MAR, we have the medications down the left side. Over the top, we have the times, and where those boxes meet up, that's where we chart our medications. Say neurochecks. There's a lot to do in a neurocheck. So do you want to sit there and write out everything, the grips, strong, equal, bilaterally, blah, blah, blah? Or would you like to have a form where you just put pluses and minuses, or, X's and O's, zeros meaning not that it didn't. So whatever the symbols say, you just use those symbols on those flow sheets. Generally, the only time you include information from a flow sheet into your nurse's note is when it's abnormal. I'm not going to write out all of my absolutely normal vital signs into my assessment because I've charted those vital signs more than likely on a graphic sheet somewhere, and the only reason I would write them in there is if the blood pressure was out of whack or temperature was elevated or pulse was elevated, then I would be writing those in. But otherwise, I'm not going to chart them 3 or 4 times if I don't have to. This is a graphic sheet. So up here we've got an opportunity to literally use a dot to put our temperature on there, okay? And then also it would have you depict whether it's axillary, rectal. We now also have the temporal, so they have you, note which type of device you use to measure the temperature. Then we've got a spot for apical and radial pulse. You're not having to do both. It's just saying which one did you do? Did you do it radially or did you do it apically? And you would fill it in. Then you've got your blood pressure. If they're sitting, I usually use the lying. I only use standing if they're actually standing. Pulse ox, all of this information, I and O, okay? And by the way, if you look at the sheet closely, so on some of these, you're going to have to pay attention to what the times are up here. Some of them start with 0, 100. So this is actually night shift, this is day shift, this is evenings, and others will start at 7 a.m. here, so this is days, evenings, and nights. So you have to pay attention to those times and make sure you're charting them in the correct location. All right, discharge. Discharge is something that we should be thinking about from the first time the patient comes in the hospital. As I mentioned before, when we talk about patients that are coming in, if it's a young person who lives, by themselves and they've had a procedure and they're going home, we assume that they're going home unless there's some reason why they can't. But if it is an elderly person who, say, lives alone, but they've had, something like, they've had a broken ankle fixed or they've had a hip replacement and it's going to impact their mobility, they may not be able to go directly home by themselves. That doesn't necessarily mean they're going to a nursing home. Maybe they're going to a home of a family member, but we have to start thinking about where those people are going when they leave the hospital. All right? So that discharge planning really does begin on admission. And the client and the family should be involved. We don't make decisions for them. That's paternalistic. We need to get them involved and figure out what their thoughts are as to where the patient should be going when they're discharged. Whenever we either discharge a patient from the hospital or we transfer them from acute care maybe over to a basically skilled nursing unit type of area, we still do a discharge note and discharge summary. So it doesn't matter where we're sending them. Discharge summaries are going to include things like obviously the patient's condition, their meds, what treatments we're doing. If we're doing dressing changes, we're going to include that information on there. What diet they follow, their activity level, and any restrictions that the doctor has imposed. We need to make sure we bring that up right from the beginning. And then any teaching that we need to do. When are they supposed to have a follow-up visit? What to expect, when to call the doctor, and then if there are any referrals that we need to make. Maybe physical therapy is going to come visit them and do more physical therapy with them. We need to make sure that those referral summaries are complete so PT knows where this patient is going to be so they can go do their physical therapy. So referral summaries say we're referring them to physical therapy or wherever, or we're sending them to an extended care facility like a nursing home. Then we need to have all of their health problems so they're aware of exactly what all, not just the acute issue. The patient who comes in with they've had a hip replacement and that's their acute problem. We need to include that they've got coronary artery disease, that they've had angina, that they've had peripheral vascular disease, any other of their diagnoses, that they're diabetic, all that has to be included. Then we're going to give them a list of their medications, again, their treatments, so they're aware of what has to continue to be ongoing. If we're sending them to an extended care facility, we better include things like their eating and sleeping habits. If you've got a patient who's a night owl, you do not want to put that patient in with somebody who's like somebody who goes to bed at 8 o'clock in the evening. That is not going to be a good setup. What their self-care abilities are, remember guys, we're not supposed to be doing everything for people. We're supposed to be helping them do everything that they can for themselves and then helping them with the things they can't do. Their support networks, do they have a good family support system or not? Their lifestyle patterns and religious preferences. Sometimes religion, can really play a part. If someone is Jewish and they are kosher, they're not going to be able to go to just any facility because they're going to want to go to a facility that has separate kitchens for meat and dairy, and they follow that kosher lifestyle that basically Orthodox Jews will always follow. So you have to take that into consideration. That is a very important thing to patients who follow that, and they don't want to have to stop doing that. That would be highly distressing for them in that situation. Now, discharging a client AMA. So this is a situation where the patient doesn't want to remain in the hospital and continue the treatment course that the doctor has laid out for them, but the doctor does not feel that it's appropriate medically to discharge the patient. Of course, the patient gets final say on that, so they can leave without permission. Now, I will just give you an aside. Sometimes when a patient leaves AMA, that means their insurance will not cover that visit, so or parts of that visit. So that's something that, sometimes insurance areas might have to explain to that client. But the bottom line is that's not our job. Our job is to get the client what they need, which in this case is if they need to leave, well, then we've got to help make that happen. They have a right to refuse treatment, medication, or all treatments and medication. When they want to leave, try to figure out why. Not because we're going to try to change their mind, but so many times it is based on a misunderstanding. And so if you can clear up the misunderstanding, then you don't have the client wanting to leave. The doctor and the patient can have a conversation, and all of a sudden everything is better. But somebody said something offhand, somebody took it the wrong way, and we have this big issue. If you can just get to the heart of the matter, a lot of times you can solve this, literally. But if that's not the case, and the patient wants to leave, we need to notify the doctor, inform the patient of the risks. If you leave here and you stop this treatment, XYZ can happen. Offer the patient the appropriate form to sign. Most of the time they'll sign it, but if they're angry at the doctor or angry at anybody, they may refuse to sign. That's fine. Don't worry about it. Get someone in there with you. They're going to hear that refusal, and then you both will sign the sheet basically saying that the patient refused to sign, and you have a witness. Still give the patient a copy of what we would consider like discharge instructions of things that you recommend that they do, things that they are emergencies that they need to call back for or come back, and never tell the patient that they cannot come back, because that is not true. Notify the doctor and your team leader or your charge nurse that the patient is actually leaving. You're also going to notify the hospital administration, the people who do the beds, because they're ready to see a discharge order, and they're not going to see that this time. And then, just like you would if the patient were actually discharged, you're going to assist them to leave the hospital. It's not going to be, well, if you can't walk out of here on your own, you shouldn't be going. It's not our call to make. That is, their right to leave, and we will assist them just like we would with any patient. Okay, that concludes the lecture for documentation. If you have any questions on any of the material, please email me or find me and ask me.